would like to invite Mohammed Jobairul Islam to have his presentation. He is a medical physicist and radiotherapy coordinator of Labaid Cancer Hospital, and he will talk on simultaneous integrated boost versus sequential boost in breast cancer radiotherapy, a comprehensive analysis of dosimetric, radiobiological, and cost effectiveness. Thank you.
Good afternoon. This is Jobairul Islam. Today I will deliver my speech on simultaneous integrated boost versus sequential boost in breast cancer radiotherapy, a comprehensive analysis of dosimetric, radiobiological, and cost effectiveness. That is my outline. So, before delivering my speech, I would like to share a quote from Hubert Humphrey. Once he said, "Asia is rich in people, rich in culture, and rich in resource. It is also rich in trouble. When it comes to the public health problem of breast cancer, I think he may not be wrong." Yes, breast cancer is a major global health issue and top causes of cancer deaths in women. According to the Globocon 2020 data, 2.3 million cases are diagnosed globally, where almost half of all breast cancer are diagnosed in Asia. Even Bangladesh has one of Asia's highest breast cancer rates. Radiotherapy is an integral part of the treatment of breast cancer, where radiotherapy reduces local recurrence by 50 to 70% post-surgery, and tumor bed boost further lower recurrence risk 5 to 10%. And it's already proven to reduce local recurrence and risk of death from the breast cancer. So, breast cancer and boost radiotherapy, why it matters? Because now a development of refined surgical techniques had made breast conserving surgery the most common approach and preserving breast anatomy while minimizing the deformity, with 70 to 90% local recurrence occurring at the original tumor site. So, focused high-dose boost to the tumor bed mitigates microscopic residual disease. And studies shown that boost radiotherapy reduced 10 years local recurrence rates from 10 to 6%, while the 40% relative risk of the reduction in the recurrence. In boost, we treated two types of the boost, where one is the sequential and another is the SIV. And now boost strategy, according to the sequential, it's very traditional techniques, where the 40 or 42.56 gray in whole breast, and followed by 10 to 16 gray per boost. And additionally 5 to 8 fractions needed for boost. First, the advantage is the simpler planning and widely accessible, but disadvantage is the prolonged treatment times, potential for dose overlaps in OAR. While SIV is 53 or 48 gray tumor bed and 40 gray whole breast, while the fractions number is the constant 15 fractions. It delivers higher dose to the tumor bed simultaneously with whole breast integration in a single plan. Whereas the advantage is shorter treatment duration, reduced patient burdens, and optimized OAR span. Whereas also is disadvantage, but now I think it's not a disadvantage. Required advanced planning, IMRT or VMAT for avoid the hotspot. As the numerous publication already published, as the one is the import high trial. So, what's my objective? My main purpose is to compare the sequential versus SIV techniques, and where is my specific three objectives: dosimetric quality, radiobiological analysis, and cost effectiveness. In inclusion and exclusion criteria, I included early stage breast cancer, post lumpectomy with clear margin, and availability of both SIV and sequential plans. And we did not exclude prior radiotherapy, bilateral breast cancer, metastatic disease, and incomplete data, etc. So, in my methodology, we using 15 patients, left-sided breast cancer, all of them, and patient treated either IMRT or VMAT, and were generated using Eclipse treatment systems using AAA algorithm. Whereas the dose administration, SIV, we treated 48 gray in tumor bed and 40 gray in whole breast in 15 fractions. Where sequential 40 gray in whole breast followed by 10 gray boost in additional 5 fractions. And the plan was evaluated according to RCO 1005, where the more than 95% of breast PTV will receive minimum equal or more than 95% of the dose, and not underdose to any part of the PTV shall not exceed 93% of prescription dose, and overdose to any part of the PTV shall not exceed 115%. But in our institute, we did not accept 115%. We accept only 110%. But where volume covered by 107% isodose line should be less than 2 cc. And we are also checked mean dose V5, V30, and ipsilateral lung also V20, 20, V4, and V8 LAD dose, as well as possible contralateral lung and contralateral breast check mean dose as the less than 2 grade. And comprehensive analysis framework for treatment plans. With analysis, dosimetric analysis, where the PTV coverage using the BED calculation, TCP models, and NTCP models. We have also analyzed the cost-effective analysis, as the total treatment cost, outcomes, times, etc., and also analysis the pair t-test significant levels. In radiobiological assessment, using the biological effective dose, or in alphabetical ratio in tumor 4 for breast cancer and OAR for 3. And tumor control probability using the Poisson model based on BED, and normal tissue complication probability using Lehmann-Kuhn-Berman model. Here is my result as the dosimetric analysis of PTV. In the both are the not significantly changed in B95, whereas the SIV is 98.97 and sequential 99.933. And conformity index also not significantly changed, but max dose and monitoring unit is significantly changed between the SIV and sequential, whereas the maximum dose is 105%, whereas the sequential is the 108%, and monitor units almost 45% reduced in SIV. In ipsilateral lung also V20 is reduced in SIV techniques, whereas the p-value also significance, V8 also significance. In heart, D5, D30, and mean dose analysis, and whereas the mean dose is whereas the 3.5 gray, whereas the sequential is the 3.78 gray, as the difference 2.91%. Is also p-value is significantly changed. Contralateral lung and contralateral breast also in contralateral lung is not significantly changed, but in contralateral breast is dose is significantly changed. There is the radiobiological analysis, where the tumor weight for SIV 86.4%, where the sequential is 81%, where the difference is plus 4%, where the p-value is significantly changed, is less than 0.001. Whole breast is the TCP value is same, and BD is same, and TCP is 93.2 SIV, and where is the sequential 89.6, where is the also significantly changed. And TCP and for heart lung is except heart is significantly changed, but NTCP for lung is not significant change in sequential or SIV techniques. So dosimetric advantage of SIV has the target coverage and conformity is PTV 95%, and SIV achieved comparable target coverage and conformity of sequential. Organ sparing in lung, better lung sparing with lower V20 also. So what is the cost effectiveness? First of all, the staff efficiency. Workload due to SIV techniques or workload reduce the treatment times in the department, and patient benefits is the fewer treatment sessions, whereas the patient's cost is reduced, and also due to shorter treatments may reduce the anxiety or the mental health and resource allocation and overall impact, also quality of life improvements. And we have analysis has the 25% treatment time reduced in the SIV, and 45% monitor unit reduced, and 33% cost reduced in SIV techniques. So in discussion, according to the IMPORT-HIGH trial, IMPORT-HIGH trial is the largest randomized study of SIV, increasing precision of confidence limits for study outcomes. Simultaneous integrated boost in IMPORT-HIGH was safe and reduced patient visit. Moderate and mild normal tissues average events, while low across all assessment with no significant difference between the trial groups. And it's increasing the boost dose beyond the higher equivalent dose in 2 gram fraction of around 60 gray causes increased fibrosis with no benefit. In conclude my lecture, while the SIV advantage, precision dosimetry, shorter treatment, and cost savings, ideal for tech-enabled centers, and sequential also simplicity, adaptable, and lower fractional dose, preferred resource-limited settings, and clinical recommendations for adult SIV where feasible, retain sequential for the high cardiac risk causes of the institutional and constants. In take-home message, in the BCS era, SIV integrated innovation from modern radiotherapy optimized outcomes where technology allows. Sequential remain pragmatic fallback for equability care. SIV maximizes the tumor control while measuring the toxicity through the radiobiological optimized dose, balancing efficacy and safety in breast cancer radiotherapy. Choose SIV for breast cancer boost. Save 30% cost per patient, reduce treatment by 5 days, and optimize resource while enhancing outcomes. Thank you.